Welcome to CDP's podcast, Practical for Your Practice,
where we give you actionable intel to support what you do, one colleague to another.
Hello, and welcome everybody to another episode of Practical for Your Practice. I'm Dr. Kevin Holloway, one of the hosts today, and I'm joined today by my fantastic, I tried to avoid fabulous,
Perfect.
my fantastic co-host, Dr. Corinne Lefkowitz. Hi, Corinne.
Hello. I noticed you also didn't say favorite, which will make Jenna happy.
I know. I was going through my head like the whole list of F words that I could use there, and I selected an appropriate one.
Thank you.
You're welcome. I am excited for our episode today. I'm going to give a little bit of background on this. So, not every year, but every once in a while, we have all of the CDP staff, faculty, everybody come together for an all-staff meeting. And this year, when we met, we had a small portion of time where we were soliciting ideas for topics of things that we haven't talked about on the podcast before that would be really relevant. And today's episode is based on one of those suggestions that was just fantastic. We haven't really talked about this topic before. Corinne, do you have any ideas?
No, because I wasn't at all staff. Actually,
That's
I had to
right.
miss it this year. So I feel like I'm going to be surprised too.
Okay, you ready? Here's the big reveal.
I'm ready.
Okay. So we have with us today CDP's own Shealyn Clinger, who has been with CDP. Well, you can tell us this in just a moment, but she suggested during that brainstorming session talking about neurodivergence and trauma, a topic we have not touched yet. So welcome, Shealyn.
Yeah. Welcome.
Thanks for having me. Yeah, I've been with CDP. It'll be 2 years in December. I'm working as a data manager on the suicide prevention programs. So I work through program evaluation. But in my kind of alter ego side gig, I'm also a licensed clinical social worker in Virginia. I have a master's in neuroscience as well. And so my passion is running a small private practice which specializes in trauma and neurodiversity.
That's fantastic.
So both personally and professionally, I understand how trauma can impact neurodevelopmental differences. And I think we're really at a point in time where we're starting to understand how those interactions, how those interactions work together much differently than we did 10 years ago.
Yeah, for sure. I was going to make a joke about so this isn't about your data management work. No.
I'm interested in this topic because that term neurodivergence is somewhat new to us, as a field. And then I also think I don't have a clear sense of what it means and what it refers to, because I hear it used in so many different contexts, in so many different ways, for so many different circumstances. So I'm excited to even just get the basic education of what we're talking about when we say neurodivergence.
Right, because I think my brain immediately goes to autism, right?
Mm-hmm.
And that's one of them. But so Shealyn,
educate
help
us.
us understand.
Yeah, so I mean, it's really kind of becoming more of a buzzword. It's been around for a while. We just didn't know what to call it. And just kind of generally speaking, neurodiversity or neurodivergence is a framework. So it's not a specific diagnosis, but it's the idea that there are natural variations in how our humans' brains develop and how they function. It can include diagnoses like ADHD, autism, like you said, Kevin, dyslexia, dyspraxia, dyscalculia, Tourette syndrome, and then specific learning differences. So, it really just isn't about deficits. It's more about how our brains process information differently.
I appreciate that as a starting point. It's not about deficits. It's about different processing. And it's a big umbrella term, which absolutely makes sense when you describe it that way.
Yeah, I mean, one of my favorite kind of sayings is if you've met one neurodiverse person, you've met one neurodiverse person, because it presents so differently. And oftentimes they can co-occur together. So I like the term neurospicy. Everyone's got their own little flavor to it. And we're in a really cool point of time where we are moving away from this deficit only kind of idea of disordered thinking, but just into how we each process things differently.
Yeah. I like that notion. What kind of seasoning do you bring to the table?
I have heard that term neurospicy before, and I love it because
I never heard that.
Brings more flavor, right?
If you think about it, how boring would life be if we were all the same?
Yeah.
For sure. For sure. Well, so let me ask you this. I mean, a lot of what we talk about on the podcast, but because the Consortium for Defense Psychology is, in the Department of War, we are talking about very often how these topics that we bring up are related to a military population. Do we see neurodivergence in a military population?
So this is one of my favorite kind of intersections of topics because it's absolutely seen in the military population. Interestingly enough, sometimes individuals aren't identified until adulthood, and military service, given its kind of background, often attracts people with really great strengths, including things like structure, intense focus, this ability to problem solve and adapt and overcome. And actually, a lot of neurodiverse people possess these strengths too. When you're in the military, they provide opportunities for routine and structure and very clear expectations and kind of this hierarchy of who to report to and accountability. And those are actually environments that compensate for differences in executive functioning and that individuals that are neurodiverse thrive in. So when we see this come up, sometimes it's not obvious until we look at things like promotion or changes in
Yeah.
their own internal structure, particularly transition out of service or retirement, big changes like parenthood or marriage. When the structure changes, that's when we can kind of see it come up.
I think back to many clients that I've seen in the military population and so, kind of of course, the huge variety of anybody, but also the variety of clients who also had kind of not necessarily the reason we were seeing each other, but had a neurodiversity component to them, in particular, folks with ADD, ADHD. We see that, not all the time, but fairly frequently. I think so when I come into this, and like I said, I might sometimes default to, and I think maybe a lot of us do, a narrow idea that neurodiversity means autism, and even, people with, high support needs autism. Maybe that's where my brain stops. This is, as you were saying, this is just kind of like a normal, natural variety among human brains. And so, of course, we're going to see that in the military population, although we might not, immediately or obviously identify that when we're seeing a new client.
Well, right. And if we go back to that idea of differences, not deficits, we are the military population that structure supports neurodiverse brains. And so we do see that. Again, it's when change happens that the adjustment might be a little bit more difficult.
Right.
Well, that seems like a natural segue to talk about trauma, a real dramatic kind of change that
Right.
hopefully a type of change for people. And we talked at the beginning of the episode about this interplay between trauma and how that might work with a neurodivergence. So what is your experience with this, or what have you seen in terms of how trauma might be experienced perhaps mostly the same, but slightly differently by folks with diverse backgrounds?
Yeah, so one of the things I did was I went ahead and got a certificate in treating trauma, and then I have years of experience in neurodiversity. So the two kind of fell in my lap. And I think one of the most important things to think about is that neurodiversity deals with the development of our brain, and trauma deals with how we process things. So neurodiversity is how information comes into our brain, where trauma is how we interpret safety and danger. And those two systems can interact. So I like to think that of our brain as a computer, and that when we're talking about neurodiversity, that's our motherboard kind of thing, whereas the software is the trauma that gets uploaded. So it can shift how we process it. So they absolutely can interact together. So for example, if you hear someone yell, or someone that's neurodiverse hears someone yell, a neurotypical might say, oh, somebody's angry. Someone that is neurodiverse might say, wow, that's making me too sensitive, like it's too loud for my ears. And someone with trauma might say, oh gosh, like, that's danger, like there's something going on. What gets really interesting is when you have that overlap of, okay, somebody is upset, that volume also hurts my ears, and that is also dangerous, right? So
Yeah.
it's multiple
Right.
symptoms activated at the same time.
Yeah.
Yeah, I was thinking about almost multiple channels, I guess, because I love that analogy of, the motherboard or the processor and the software that's uploaded and the interplay between those. That makes so much sense.
Well, and I even think too, I was going to say like the way that trauma interacts with the motherboard, the brain development is going to depend on how that brain developed. Like you said earlier, right? You've met one neurodiverse person, you've met one neurodiverse person, and we have so many different, infinite varieties, combinations, whatever of any of these humans. And so much of the time, like we talk very often about meeting the human in the room, being with the human in the room. You're not treating a specific disorder, you're treating a person who might have a disorder. And so similarly, this is one of those pieces of understanding that person, or sitting with that person in the room with us. But it is interesting to think about like the many ways that it can interact. That was a great example, Shaylin, of like a loud noise. But can you tell us a little bit from your experience, like what are some of the challenges that are perhaps unique to somebody who happens to be somebody with a neurodiversity? Again, probably depends a lot on their specific manifestation of it, their experience of it. But can you tell us some experiences of how that interaction can look?
Yeah, I mean, like you said, and I've said it, it's so different from person to person. And what's really interesting is that some of the effects or symptoms of it overlap with trauma, right?
Uh-huh.
Mhm.
Uh-huh.
And so what's really important is to kind of deduce what belongs in what category. So we could think about attention, right? We often think that ADHD is an inability to pay attention. And actually, that's not exactly the case. It's the inability to switch, it's a motivation to pay attention, right?
Right.
So, what we should be thinking about isn't necessarily is this trauma or is this neurodiversity? It's what system is impacted, how are they interacting, and what is the person's nervous system needing. So when we're thinking about things like neurodiversity symptoms and PTSD symptoms, we're looking at things like maybe hypervigilance, right? Is that
Mhm.
hypervigilance or is that an inability to shift attention? Um,
Yeah.
Loud noises, right? We're talking about sensory processing things, sounds, textures, lights, movements that can all be part of someone that is neurodiverse. But also think about that. That could also be trauma, right? So, what
Right. Right.
happens after that sound happens? If a door slams or there's a loud boom, um, again, if you've experienced trauma, that can be interpreted as danger
Mhm.
or being very overwhelmed. Um, Threat detection, too. So, someone that's experienced trauma could perceive that as something that's dangerous happening, whereas someone that's neurodiverse is trying to decide how to process all this incoming information at each other. So there are a lot of things that overlap. Sleep is also, I know we've talked about it at CDP a lot, both commonly impact sleep as well. So either an inability to go to sleep because you're having racing thoughts or difficulty settling down. With trauma, that could look like nightmares or hypervigilance or waking. And we know that sleep is so important that those impact our ability to pay attention, to remember
Right.
things, our own emotional regulation. And so the truth is that you see a lot of very similar side effects or symptoms in both trauma and neurodiversity. The question is, what's the function of this? Where's this coming from?
Right.
Yeah.
Right.
Yeah, which I imagine is difficult, if not impossible, to necessarily discriminate between one and the other, right? You just have to treat the whole person and treat the whole um, presentation.
Well, yeah, it's I love that we're in a time where we are kind of shifting to this stopping asking if someone's brain is normal, but better
Yeah.
shifting to how can we help this person succeed, right?
Yeah.
And when we can make that shift and we understand that, our treatment becomes much more collaborative with our clients. It becomes much more person centered. We're not trying to fix the broken brain anymore, but we're
Yeah.
trying to understand how an individual's nervous system is developed, right? And then how it's been adapted or changed or influenced by the environment around them.
I was thinking that has a big impact on when we're thinking about trying to tease out, like as you were trying to say, like Is it from the trauma? Is it from their neurodiversity, is their development? Part of it is that we need to recognize that, while trauma is going to have an influence on that person and their particular uniqueness, there is very often with trauma kind of this before the trauma and after the trauma functioning. And we can kind of think about what was typical, normal for them prior to the trauma. We're not trying to get them to a bell curve normal of the population kind of functioning. We're trying to help them to recover, return to what is normal functioning for them. And that needs to be part of that calculus, that understanding as we're working with that person.
Well, right. And I think the other part, there's a kind of a two-part answer to that is that it really comes into play how important developmental history is. So we want to
Absolutely.
look at
Yeah.
childhood patterns. We want to look at when some of these things started to emerge and if that was pre-trauma or post-trauma. And then to Kevin's point, it's healing isn't about making someone quote unquote, being neurotypical
Yeah.
again.
Yeah.
It is about providing a support system that helps regulation, reduces their distress, and helps them be successful in the life that they've built.
When I ask my next question, it might sound like I just ignored everything that you just said, and I swear that I didn't. But you've had me thinking in my mind a question about vulnerability to trauma,
Uh-huh.
because I'm thinking about, obviously folks who serve in the military, they have higher risk for multiple types of traumatic experiences because that they are serving in a capacity where that is present. Do you know of any data? Do you have any information for us about whether individuals from neurodiverse backgrounds also have an increased risk for traumatic experiences?
They do, and often in childhood, right?
Yeah.
There is data showing that children that are neurodiverse are harder to parent, and because they have different needs, and so that leads to a higher rate of trauma. But also, you're looking at instances of bullying or not
Yeah.
fitting in and
Uh-huh.
trying to conform, and so all of that as well can be very traumatic. I mean, goodness gracious, growing up and being a teenager is traumatic enough without all of the other
Right.
things going on. And so, yeah, absolutely.
Yeah.
And even systemically too. I mean, I feel like society's getting better at recognizing neurodiversity and recognizing, kind of the unique needs of folks that are neurodiverse. But at the same time, like even our school systems are still
Mhm.
working on, catching up with that idea where the structure of public schools, for example, is very much directed towards a neurotypical child,
Mhm.
right? And so even not just the bullying, not just the difficulty parenting, but even systemically, we have some challenges for neurodiverse folks in their development.
Mhm.
Well, and Kevin and I were talking previously is especially true with women and girls. I'm having a lot of women in their 20s and 30s coming to me and just initially being diagnosed as ADHD because women, girls and boys, they present so differently.
Right.
And
Yeah.
oftentimes you are kind of seen in the school system, and that's where neurodiversity is first identified. But that's often because kids can be disruptive in class or create behavior issues because we're lacking that emotional regulation. Oftentimes, females are really great at masking, will internalize more, have more of kind of this perfectionism or daydreaming, which isn't creating as much disruption in the classroom, and they're missed. And so that's one of the things that we've been talking about in the community is really identifying that as well.
Hmm. Yeah.
That's interesting.
Okay, so let me ask the big question.
Yeah.
What do we do as providers? Like, I mean, we talk all the time on the podcast. We have a lot of training workshops on evidence-based psychotherapies for PTSD, such as prolonged exposure, cognitive processing therapy, EMDR, trauma-focused CBT. Like, these are
Mhm.
fantastic therapies. Do we just have to throw those out the window when we're working with folks that, are neurodiverse, or are there adaptations that we need to be aware of, or are we generally approaching this in a similar fashion, recognizing that there is a unique human sitting in front of us? Like, what would you say?
So, the truth is that we as providers should meet our clients no matter who they are, no matter what diagnosis they are,
Good
exactly where
point.
they're at.
Yep.
Mhm.
And so we got to be real careful about creating discrimination or ableism within our own treatment. So I would give you the same advice that I would give and I hope you would do with any other client. So slow down. Don't assume anything. Don't
Yeah.
assume it's trauma. Don't assume it's neurodiversity. Take a really great developmental history. Ask questions, at what age did you start to notice X, Y, and Z? Or what happened after this deployment? What did you notice after the trauma was happening? What changes did you see? And, yeah, adapt the therapy. Keep our wonderful EVP or evidence-based practices, but don't expect clients to adapt to us. So
Right.
we might
Right.
need to provide things like visual aids or written summaries, kind of a predictable schedule, really concrete language, a timer on the screen when we're in session so individuals can know when that's up. Sensory awareness too, whether you're virtual or in person, lights down low, sounds. Ask your client what they need to feel successful in therapy, right? If we can shift to a nervous system perspective, we know that if someone is dysregulated, they aren't able to be present and be engaged in therapy. So think safety first, skill second.
This reminds me so much. I don't know if it reminds you, Kevin, as well, of an episode that we did a few seasons ago talking about trauma-informed care. It's one of our favorite, both of our favorite episodes, where we talked to, I believe it was Lydia Bartholomew, and a lot of her suggestions were exactly in line with what you're describing now, Shaylin, really thinking about how to set up the environment, how to set up the structure in a way that, first of all, you ask what the patient needs, actually outright ask about it, and then take these steps, which may seem really minor to somebody who's neurotypical, but might make a really big difference for somebody who is processing things differently.
Well, and we're all different types of learners. Some are visual, some are auditory. And so even engaging the different learning styles in our therapy really is going to help our clients be present and get the most out of therapy. As far as exact examples, when we're doing, um, you know, CBT, for example, and we're sending out homework, go through the homework first with them, shorten the assignment, send reminders out. Hey, we've got this session. I know a lot of that's automatically done, but individuals might need a little bit more, but ask them what they need to feel successful.
Hmm.
Instead of assuming that it's avoidance,
Yeah.
right? Yeah.
Yeah,
Yeah.
exactly. Instead of assuming it's avoidance, right?
Ouch,
Well,
that felt personal, Kevin.
that wasn't directed your way, but you can feel what you feel. I do think it was striking me that in many of our evidence-based psychotherapies, there tend to be manualized treatments, and yet when we're training them, we really, really strongly encourage the learners, the participants in those workshops that look, this is not a checklist to say this thing, hand out that form, now do this activity in this way. It's more of a structure of here's generally how we're going to approach this, and yet it's very individualized. It's very specific to that person and their experience and what their understanding of their symptoms and their trauma was. There's room for this in our evidence-based psychotherapies, in our protocols, because they're not rigid. They work
Hmm.
best when we flexibly apply them and remember that there is a human here that we're working with.
Well, and therapy also is a collaborative relationship between two people,
Yeah.
right? And so having that conversation of um, what, how can I help create the condition for you that you operate best in? It's not our role to make a behavior stop, but we do need to take a closer look at, an individual's nervous system, right? So what is making this exacerbating this individual's nervous system or their executive functioning, and how can we create an environment that's going to be more supportive of that?
Yeah.
Shaylin, this has been such a fascinating conversation already, and there are things that you've said that I think I can take and just immediately start applying to the clinical work that I do. So I'm very appreciative of that in of itself. I'm wondering if we can hear a little bit about an impactful moment, if you will. That's been the theme of our season so far. Um, Asking our guests how, not necessarily how or why they got into this subfield, but more so, is there a moment that stands out that really affected you, that made you feel more strongly about what you were doing, that made this work really worthwhile, made you more passionate about it? Anything that stands out to you?
Yeah, so I started this work in my 20s. And when I was in my undergrad program working with kids that were on the spectrum, and I would shift and change, and somehow it always come and pull me back in. I would say the biggest change for me is I had my own daughter, and when she was born, she showed some motor differences, and
Hmm.
she's highly intelligent. Um, and so it was really hard to get a diagnosis for her. I really had, and even being in this world and knowing the language and knowing what to look for, I had to really, really advocate and say, no, listen, there is
Yeah.
something here. Let's talk about it, both in the schools, both with her doctors, both with neurologists. And I was thinking, I have all these years of experience and I'm having to push and
Right.
advocate this
Right.
hard. What about those that don't? And so that's really drove my private practice home for me is we need to normalize this. We need to talk about how we can support our community, ourselves, and stop looking at, why isn't someone doing this, but more of a shift to what's getting in the way. And I think that we can make, if we can make that shift, that perspective changes everything. So, what instead might look like resistance, maybe that's executive functioning challenges instead. What,
Yeah.
Kevin said about avoidance, maybe that's sensory overload, right?
Yeah.
Especially in parenting. What might be a lack of motivation, or I cannot stand this term, but someone being lazy, is actually a nervous system shutting down because they've been in survival mode for just years, just trying to exist. So we are, as clinicians by the DSM trained to look for symptoms, right? Do they meet
Mm-hmm.
these criteria? But I think when we can look a little bit deeper into the behavior and we take the context into it as well, that changes how we can practice. And having both that personal and that professional experience for me was game changing.
Hmm.
Yeah, thank you for sharing that.
I gotta say that it feels like not to Shaylin, thank you for sharing that, and not to
Mhm.
in any way, minimize that. This is a story I think we've heard from a lot of guests, Corinne,
Yeah.
right? Where
Right.
we have somebody who knows the lingo, who is part of the field, who's part of the
Mm-hmm.
system, if you will, and they have significant challenges
Yep.
finding the resources and the support and the help that are needed for themselves or for somebody that matters very much to them. And imagine the struggle and the challenge of folks who are not in the system and who don't
Mm-hmm.
speak the technobabble language, and that it's a reminder to me every time it comes up that we've got to be compassionate, more open to those folks who are not part of this language, if you will, and helping to advocate navigating this weird system we call mental health in the US.
And there's so many systems that integrate with that. Kevin, you mentioned
Absolutely.
the school systems and just the medical field in general, because a lot of times with neurodiversity, you're going to see need for physical or occupational therapy. You're going to need
Mm-hmm.
speech therapy. You're going to need medical resources. You're going to need educational resources, and they all interact with one another. And so having to delegate, get support, advocate in each one of those areas, that's exhausting too for yourself and if you're doing that for others.
Yeah.
I was about to say thank you for becoming an advocate, and I stopped myself because I feel like in some ways that's a dirty word sometimes. Like it's exhausting. Why should you have to be the advocate? It's unfair that you have to do that. And also, I'm really glad that you're doing that work and that you have the drive to do that and to advocate not only for your own family, but for all those clients and families out there who need the attention.
Well, I thank you very much. I appreciate that. But honestly, I learn and grow so much from the individuals I work with. And I think that's the why we do what we do, right? Is to make that human connection. And it's such a gift.
For sure.
Mhm.
Well, I wanted to ask you this as we're kind of wrapping up here. We like to leave each of our episodes with, some ideas, some tips for our listeners of how they can apply what we've been talking about to their practice right away. We call it actionable intel. So,
Mhm.
what thoughts do you have? What can folks who are listening to this take with them after this episode to apply right now to their practice? And this could be resources, this could be URLs, it could be, just some practical tips.
Incoming actionable intel.
So I think it would be the first thing I would say is shift the perspective on how we address our clients. So really shift into that nervous system perspective. And if we can stop looking at the client as a list of symptoms and thinking what's quote unquote wrong with them, and start asking, how they experience the world and what they need to heal, that perspective change is going to make a huge difference and a huge impact in your therapy room. And then from there, it's again, asking what they need, how you can tailor the treatment to what will help them be most successful. There are some really great resources out there for depending on what neurodiverse category you fall in.
Right, right.
Attitude for ADHD is one of my favorite. There are resources for clinicians, for parents, for women, for men. I can also send some links to include
That'd
as
be
well
great.
for others.
Yeah.
But I think really it's the shift that happens with the clinician and in the room itself that's going to make the biggest impact.
Yeah. Thank you for that. And we'll include all of those links in the show notes for all of our listeners to look up and be able to take advantage of.
Yeah, but I like that reminder of it starts with the clinician's attitude, the
Yeah.
provider's attitude, and attention to what's going on in
Yeah.
the room.
So often I think we underestimate the power of validation.
Yeah.
And that has a huge role.
Yeah. And one, if I might, add that came up quite a bit today is, doing a good developmental history as part of your very good assessment, a comprehensive assessment, right? And I know that's been a theme on the podcast at times too. It's like, it's got to start with a good comprehensive assessment, and including that, good developmental history of that person in front of you is so important. So I'll add that one to the list.
Absolutely.
Yet another time where we know, like, we tend to gloss over the assessment piece and we run straight to the treatment. But yes, good reminder, the assessment piece is actually pivotal.
Yeah. Thank you so much for joining us, Shealyn. This has been really interesting and
Enlightening.
again, making me think about things in ways that I don't always end up thinking. So yeah, very enlightening.
Thank you so much for being here.
Thanks for having me. I really enjoy this topic. And I am so grateful we're living in a place where we can have these open and honest conversations, and that, neurodiversity doesn't have to be a dirty word or something to be ashamed about anymore.
So true. Thank you also to all of our listeners who are joining us again. Like, we appreciate you tuning in and going with us on these journeys. Like, we appreciate it. So we'd love to hear from you. If you would like to share your impactful moment with us, you can send us an email, or you can leave us a voicemail on our speak pipe, or, anything else you want to share, any questions for our guest, or sharing your own experience in working with neurodiverse folks in your practice. Go ahead and leave us an email or a voicemail, and we may feature that in a future episode.
Yeah. Please reach out, keep in touch, keep listening. And in the meantime, stay curious.
And mind your EVPs.
Bye, everybody.
Bye, everybody.
Be sure to subscribe to Practical for Your Practice to be notified when new episodes arrive. Our theme music is Failed Attempts by Nitro, and our administrative assistant is Bree Mercer. This podcast is produced by CDP at the Uniformed Services University of the Health Sciences. The views expressed are those of the speakers and do not necessarily reflect the opinions of the Uniformed Services University, the Department of War, or the U.S. government. In addition, references to any specific companies, products, processes, or services does not necessarily constitute or imply endorsement by the Uniformed Services University, the Department of War, or the U.S. government.